probably start. What time is it? Sorry, we had a few technical issues to begin, so we're starting a tiny bit late, but I will go through these introduction slides very quickly, as many of you will already have heard this spiel before. But before we start, I'd like to acknowledge that we're hosting this event on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We are very thankful and indebted to our sponsors, without whom we couldn't host this event, particularly from CIHR and the Michael Smith Foundation for Health Research, but also a generous donation from Elizabeth Rideout, who has a CIHR Sex and Gender Chair. And we're using Slido, as many of you may be familiar with, so please just put Slido in the Google, and the event code is 47504, which you should have had in your invitation. Follow our conversation. There's a Twitter hashtag if you want. And of course, feel free to join us. Again, that's an old thing. You can just join us by filling out the form on the Women's Health Cluster page. And also please consider donating to our small little group as well. And with that, I would like to introduce our first speaker, who is Xiaoming Wei. And her research focuses on the neuroregulatory effects of ovarian steroids in women. She is a MD and professor at, I believe, National Institute of Health. Is not on my so you can say that. Xiaoming, feel free to share your screen.
You're doing great.
It's on your it's on your first slide anyway. And she's completed studies informed by basic science findings that document the regulatory effect of estradiol on genes relevant to brain function. I will tell you that estradiol is my favorite hormone, even though I'm not supposed to say that out loud. It is true. And she uses multimodal imaging platforms, including PET, SMRI, and fMRI, to explore brain regions targeted by sex steroids in healthy women, as well as women with postmenstrual dysphoric disorder. She's developing a new initiative using multimodal brain imaging to study the effects of ovarian hormones on dopaminergic function during postpartum psychosis. Very interesting. And Xiaoming, please feel free to share your screen when you're ready. I also ask them always for a fun fact, and her fun fact is that she did competitive show jumping throughout middle school. So with that, I give you Dr. Xiaoming Wei.
All right, thank you very much, everyone. Trying to figure out a way to advance my screen. That's it. Great, perfect. All right, so hi everyone. It is a pleasure to be here and sharing some of our work done in the Behavioral Endocrinology branch and the National Institute of Mental Health. Today's talk, I'd like to focus on premenstrual dysphoric disorder, or PMDD. So from what we've learned from our studies in women with reproductive endocrine-related mood disorders, and that would include premenstrual dysphoric disorder, or PMDD for short, but also depression during the perimenopause transition and postpartum depression, is the idea of a differential sensitivity in which the same hormonal stimulus elicits a behavioral response in women at risk, distinct from the seen in non-affected women. And that we've also found that the nature of hormonal trigger differs across conditions. For example, hormonal exposure in PMDD, which I'll show you later on the talk, is an exposure to hormones, whereas in women with perimenopause depression, it seems to be a change in hormonal levels. So from high levels to low levels, or withdrawal of estradiol. So just as a background, the role of hormones in PMDD show that levels of ovarian steroids are not abnormal. This is not a typical endocrinopathy like hypothyroidism or Cushing's disease. In fact, in our study using progesterone receptor antagonist RU486 in combination with HCG, we were able to show that under blinded conditions, we can eliminate the mid to late follicular phase, mid to late luteal phase of the menstrual cycle and have no impact on symptoms. And this suggests that the events earlier in the menstrual cycle probably would be triggering PMDD. We then looked at the effects of complete suppression of menstrual cycle with the GnRH agonist Lupron. And this is the design of the hormone manipulation protocol using the GnRH agonist Lupron. Whereas after baselines of menstrual cycle, we can confirm women with PMDD prospectively. All these women were placed on Lupron for 6 months. So during the 6 months, the ovarian cycle is completely suppressed and no estradiol or progesterone is produced by the body. You essentially go through 6 months of artificial menopause. After 3 months of being on Lupron alone, where estradiol and progesterone are fully suppressed, we then identified women with PMDD who experienced a remission of PMDD symptoms. And this is about 70% of the women in the cohort. About 30% of women do not respond to hormone suppression and they would continue to experience symptoms. So in the women who did respond, we continued them for an additional 3 months on Lupron. And during this time, we added back physiologic levels of either estradiol or progesterone in a double-blind crossover manner for 5 weeks each, followed by a washout period. And this can be seen in the right-hand side of the graph. So this study, this protocol is designed to allow us to study brain function in the, or behavioral effects in the absence of ovarian function. That's during the Lupron alone period, as well as during the separate administration of either estradiol or progesterone. This is the pattern of symptoms that we observed from this hormone manipulation protocol. On the y-axis is the symptom of sadness, which is done on a daily basis. And each of the bar represents the 7-day average of this symptom. And higher levels of number represents more symptoms. So on this scale, 3 is more sadness compared to 1, which is no sadness. You can tell that we, from the Lupron alone, which is the black bars, we see a remission of symptoms and elimination of symptom cyclicity for the first 3 months. Whereas on the right, during estradiol and progesterone add-back in red and blue prospectively, we see a recurrence of symptoms on the 2nd or 3rd week of hormone add-back. Now, to control for the hormone manipulation paradigm, we also recruited controls who were confirmed to have PMD, who were confirmed to have no PMDD symptoms, or they have absence of PMDD symptoms. And you can see that they experienced no symptoms during neither of the 3 hormone conditions, neither in Lupron nor in estradiol or progesterone replacement. What these data show is that a large number of women with PMDD would experience symptoms remission during hormone suppression and symptoms recurrence when physiologic hormones are added back, suggesting that there is differential sensitivity in the women with PMDD when responding to ovarian hormones, like I mentioned earlier in the talk. Now, we employed the same paradigm to explore the potential neural underpinnings of this differential behavioral sensitivity in response to hormones in women with PMDD. So this is the same protocol that we've been using. And in addition to manipulating hormones, we scanned women 3 times in 3 scan windows during the course of the 6 months protocol. So 1 during the hypogonadal baseline when symptoms are absent in PMDD, and 1 during estradiol add-back, and 1 during progesterone add-back. There are 2 main advantages for using this protocol to investigate brain function during, and 1 is that it allows us to investigate the effects of hormones not in a natural menstrual cycle setting, because either estradiol or progesterone are always, they always appear simultaneously during a natural menstrual cycle. And more importantly for women with PMDD, the hormone suppression scans during the Lupron only state will allow us to investigate brain activity when symptoms are in remission. Second, this protocol can parallel experiments done in animals where the effects of estradiol and progesterone can be studied separately. In this study, we used positron emission tomography, or PET, to study basal resting brain function. or regional cerebral blood flow in controlled women and women with PMDD. HeLTI has been a gold standard method to measure brain functions for several decades, and its technical stability is crucial for clinically demanding studies that spend significant periods of time, such as this hormone manipulation protocol that takes 6 months to collect a single data point. And we found that in the subgenual cingulate, which is the yellow dot circled by a red circle, this region is differentially modulated by ovarian hormones in women with PMDD. I'm going to break this finding down in a graph. This is our post-hoc analysis. On the x-axis, on the left is controls, right is PMDD, women with PMDD across the 3 hormone conditions, lupron, estradiol, and progesterone. On the y-axis is basal resting regional cerebral blood flow in the subgenual cingulate. So we'll first look at the controls first. You can see that across all 3 hormone conditions, there are no changes in the regional cerebral blood flow in the subgenual cingulate. Whereas in the patients, we can see a steady decrease in regional cerebral blood flow when we added back estradiol or progesterone. And what's important is that between controls and women with PMDD, we found differences in regional cerebral blood flow in the estradiol condition as well as the progesterone condition. We also found within, in women with PMDD, that compared to the hormone suppression state, the progesterone had decreased regional cerebral blood flow, as well as estradiol. So the subgenual cingulate has been implicated in a number of affective disorder, including structural and functional abnormalities in major depression disorder. What's interesting to note that the subgenual cingulate has been a target for deep brain stimulation to treat treatment-resisting major depression, and it also has high concentration of serotonin receptor, which currently is one of the frontline treatment for PMDD. So this diagnosis by hormone interaction in the subgenual cingulate would suggest that this could be a reaction to affective instability that is induced by ovarian steroids and PMDD, like the ones I just demonstrated, where they experience remission of symptoms during hypogonadal state and a recurrence of symptoms during either estradiol or progesterone exposure. It could also imply that subgenual cingulate is a neuroanatomical locus that is directly mediating symptom expression and is differentially regulated by ovarian steroids and premenstrual dysphoric disorder. So we employ the same clinical phenotype. Sorry. In the next section, we went on to try to understand these behavioral and neuronal findings that reflect the differential sensitivity to hormones in women with PMDD on a cellular level. And we asked the question, is there evidence at a cellular level of the differential sensitivity to ovarian steroids identified in women with premenstrual dysphoric disorder? We employed the same clinical phenotype that were identified in our study of women with PMDD and controls, and we took bloods from these women. And cell lines were created using Epstein-Barr virus vectors to create immortalized lymphoblastoid cells. We first determined whether these cells expressed sex steroreceptor messenger protein. So were these cells capable of responding to either estradiol or progesterone exposure? And the answer is yes. We determined that they did have this machinery in place. And we cultured these cells in sex hormone-free medium so that we eliminate all potential ovarian hormone effects on these cells. Then cell lines were taken after this culture and whole transcriptome sequencing was performed. And differential gene expression was analyzed using several different types of pathway analysis. In particular, we identified a differential gene expression in one family of genes, the ESC-EZ complex. The ESC-EZ complex is a family of 13 genes, and it's part of a polycomb repressor complex 2, catalyzes methylation of H3K27 to either a di or trimethylation, and it regulates transcriptional response of a wide range of genes. It's also important to note that this particular complex is regulated by sex steroids and can modulate sex steroid function on other cells. So these are the data from this set of experiments done by Dr. Dubey and Huffman. They identified in a baseline untreated cell sample, so these cells were not treated or exposed to estradiol or progesterone, in 10 women with PMDD and 9 controls. And we identified increase relative to control, which is on the y-axis, represents percent change from control. In that out of the 13 genes, the majority of genes showed increased change in gene expression compared to controls, with only 2 genes showing decrease in gene expression. And 6 of the 13 genes showed a positive increase in gene expression compared with controls. We then were able to replicate these findings in an independent sample of women with PMDD and controls, and we employed a different method to quantify gene expression using qRT-PCR. And it is in a larger sample of women, 24 women with PMDD and 24 controls. We confirmed that the overall pattern of increased gene expression and the number of genes in the ESC-EZ complex. So again, about 5 to 6 genes showed increased gene expression compared with controls, and only 1 gene showed a minor decrease in expression compared to controls. So what we then build on these findings of untreated, non-exposed estradiol or progesterone cells and expose these cells to either estradiol or progesterone. Since many women with PMDD, like I mentioned before, experience symptoms recurrence when these hormones were added back. So added back estradiol, progesterone using RNA sequencing, and we found that was the overall expression, again, this is on the y-axis now, showed a differential response to either estradiol, shown in blue, or progesterone, shown in purple, in women with PMDD compared with controls. So these data have shown us that there are baseline differences in the ESC-EZ complex in gene expression, and that ovarian hormone exposure results in differential ESC-EZ complex gene expression. Now, what do these suggest? Is that maybe in women with PMDD, that the alteration in the ESC-EZ complex involves an epigenetic modification and changes in methylation, that there may be a capacity in women with PMDD to transduce environmental events, such as early life trauma or prolonged stress, into long-term effects of gene expression that then is different from the controls. Interestingly, in a very preliminary study, we look at the overall gene expression pattern of this ESC gene during baseline, so untreated cells, and we correlated these expression patterns to the regional cerebral blood flow changes in the subgenual singlet that I just shown you in the previous slides. We found that in women with PMDD, there's a correlation between baseline ESC expression with subgenual singlet regional cerebral blood flow. And these preliminary data suggest that there may be a cellular modulation underlying the changes of neural underpinning of the changes in subgenual singlet in women with PMDD. So in summary, we have observed a behavioral differential sensitivity to hormones in women with PMDD, and that there potentially is a neuroanatomical hub, the subgenual singlet, that is underlying the observed differential sensitivity. There is evidence of cellular modulation within the ESC-EZ complex, and future direction would include investigating the role of the subgenual singlet and the pathophysiology or treatment of premenstrual dysphoric disorder. We'll also develop new neuronal cell lines, including induced pluripotent cells, and investigating microRNA's roles in these more basic cellular level changes. And finally, observing some changes in calcium signaling. So with that, I'd like to thank everyone in the section of behavioral endocrinology, especially my mentor, Dr. Peter Schmidt, and everybody else in the lab. Thank you very much for your attention.
The problem with Zoom is we can't hear audible claps, but I urge the audience to send your little emojis if you so desire. Thank you so much. It's always nice to have that feedback. In fact, the speakers are allowed to unmute themselves and ask questions, because right now, Slido, don't forget about Slido if you want to ask questions. And maybe I'll take prerogative by asking the first question, if I may, which is, did it matter? Because I think in your paradigm you have, estradiol, you're getting estradiol and progesterone. Did it matter if you gave estradiol first, then progesterone, or progesterone first, then estradiol? Did you get the same effect?
That is a very interesting question and an important one in study design. So we try to eliminate order effect of having these counterbalance. So some women would get estradiol first, then progesterone, get the opposite. Now, when we unblinded these results, we actually tried to look for an order effect. So meaning that I was looking at whether estradiol, progesterone introduced first would affect the results, and it didn't. So we did not have an order effect. Now, we couldn't really investigate the order effect of the hormone suppression because we had to do that first.
Right. Can't have one without the other.
Right.
I thought it was really interesting. I was going to ask you about iPSC cells, but I guess we have to wait for that data. And I know that it's technically challenging, but do you have any like idea? Do you think it will differ depending on what cells you're looking at?
I mean, so that's an interesting question, because we obviously saw some changes in lymphoblastoid cells, which are peripheral cells. They're not neuronal cells to start with, but we know that compared to neurons, the lymphoblastoid cells have about 80% gene expression overlap with neuronal cells. So we believe that our lymphoblastoid cell findings would represent closely to using actual neuronal cells. But since we already have the bloods and we are trying to make these induced pluripotent cells, it would be interesting to try to see if these findings would replicate in a neuronal cell.
Mm-hmm. And it might, I mean, even if it doesn't, that's still really
that could mean something. I think my hypothesis would be that there would be changes in
my printer is like,
we're looking at a state and versus trait changes in these cells, like we've observed.
So if there's no other questions, we have some time. My silly printer is like, I don't know, there's some demon that's in my office right now, turning my printer on. So I'm going, without further ado, I think we'll move on, because I know Cindy Lee has a time crunch today. So I will introduce Dr. Cindy Lee Dennis, who's a professor in nursing and medicine and in the Department of Psychiatry at the University of Toronto. She also holds a women's health research chair at Lai Kai-shing Knowledge Institute in St. Michael's Hospital. And she's currently a principal investigator of 7 large multi-site studies and is a co-investor in 24 other research projects. Do you sleep? I'm just
it's busy.
Concerning paternal and infant health outcomes with a focus on perinatal mental health. She holds over $23 million in funding from CIHR, which is our NIH equivalent, I guess. That's what I think of it. It's Canadian Institute of Health Research, as principal investigator, and has over 200 peer-reviewed publications. She's a lead author of 8 Cochrane systematic reviews. She's very well accomplished, and I always ask everyone for a fun fact, but she won't let me disclose her fun fact. So I'm wondering.
No, I said I would. I said my fun fact is little Winston.
Right.
I forgot.
Winston. It's Winston, right? Was that it?
Yes.
Oh, he's so cute. I'm so glad that everybody got a chance to see Winston.
There we go.
There you go. That's your fun fact.
So how about I start?
Yes, please.
Okay, let me share my screen. Okay. Sorry, had this set up. There we go. Okay, so thank you, Dr. Wei, for your presentation. It was very informative. My talk today is very different. It's more within the clinical realm of what we do in public health and in primary care. And I'm going to be talking about mental health across the perinatal period and talking a little bit about preconception. So let me first start that reports of mental illness related to childbirth dates back to the Middle Ages, but we've really only been addressing the clinical symptoms of perinatal mental health issues within the past 30 years, primarily starting with depression in the late 80s. Postpartum depression, we now have thousands and thousands of studies on it. We have very good meta-analytic data to suggest that prevalence rates in high-income countries range between 7 to 13%, and other meta-analytic data with low and middle-income countries saying that it's significantly higher. It's greater than 20% in some of these countries. Whether the incidence of depression starts postnatally is questionable. In a very large study that was completed in the UK, 33% of women with depression actually developed their symptoms in pregnancy. So women that we are assessing in the postpartum period, 33% of them had their symptoms start in pregnancy, and a further 27% had their symptoms start pre-pregnancy. And that's one of the reasons why we've seen a push from talking about postpartum depression to perinatal depression and depression across pregnancy and into that postpartum period. Although the majority of the episodes resolve within a few months after we initiate treatment, 1 in 4 women still remain depressed after that first year postpartum, and about 40% of these women will relapse again. So if they've had a postpartum depression experience, 40% will have depression again at some point in their lives. When we talk about postpartum depression risk factors, there's been a multitude of meta-analyses completed. We know that the strongest risk factor, hands down, is past history of depression, whether it's postpartum depression or perinatal depression or depression independent of childbirth. And then we see a lot of psychosocial types of variables, whether it's related to the supportive environment that they live in, or whether they have a poor a child in poor health or a difficult temperament. We also know that perinatal mental health issues are intergenerational. So if a mother has experienced postpartum depression, then her offspring are at very high risk of developing depression as well. We've done a fair amount of research related to migrants here in Canada, and we've completed a systematic review actually of prevalence rates with immigrant women here, and we found a pooled prevalence rates of 20%. So very common to rates we see in low and middle income countries. This prevalence rates from 18 studies, including over 14,000 women. And if we compare immigrant women versus non-immigrant women, we see that immigrant women are 2 times more likely to develop depression than non-immigrant women. And that is from 15 studies and a sample size of over 50,000 women. So we're pretty confident in these rates that we're reporting here. When we think about child developmental consequences, we have very good meta-analytic research to suggest that it impacts their cognitive development. So it predicts poor language and IQ development if the child has been exposed to a depressed parent. We also see behavioral developmental issues. In a meta-analysis of over 193 studies, we saw an impact on both internalizing and externalizing behaviors. And in another meta-analytic study, we see that it impacts their emotional development. In particular, it impacts their attachment to others, and has the results, they also have difficulties in self-regulatory types of skills. We've seen a big movement more recently towards the developmental origins of health and disease. It's called the DOHED. And they have a hypothesis stating that healthy growth and development in pregnancy is critical to an optimum lifetime of health and well-being. It's the saying of what happens in the womb lasts a lifetime. And based on this type of thinking, we've started to look at perinatal mental health issues in pregnancy. And we see that antenatal depression is also linked to poor child developmental trajectories, and that the prevalence rates of depression in pregnancy are almost identical to the depression rates that we see in the postpartum period. So it's highly common and prevalent. But what's really interesting is the study conducted by Kathy Wisner and her team in the States. And this was a huge screening study that they did. And of the 727 depressed women that they found, those with pre-pregnancy or those who have developed depressive symptoms either pre-pregnancy or during the pregnancy, instead of looking at the sample of women who had depressive symptoms that started in the postpartum period, they found these really important differences. So the ones that had depression that started pre-pregnancy or during pregnancy tended to be younger, non-Caucasian, lower educated, not married. They tend to have more than 2 children and do not have access to private health insurance. So if we were only looking at depression in the postpartum period, we would miss a significantly vulnerable maternal population antenatally. And this is sort of important because what they found in this study is that women who had depressive symptoms in the postpartum period, those who had severe symptomatology tended to be those who had their depression start either pre-pregnancy or pregnancy onset. So even in terms of treatment management, looking at treating people just in the postpartum period, you'll have women who could have been treated antenatally, and we could have minimized more of the treatment options that were available. In addition to talking about postpartum depression, there's been a really great movement towards addressing anxiety in the perinatal period, though not as popular in the research literature. Anxiety has been shown to also be linked to poor child developmental outcomes, and this is not just anxiety in the postpartum period, but also anxiety in the antenatal period. So anxiety tends to also be more prevalent than postpartum depression. So looking at anxiety is very important as we think about the range of perinatal mental health symptoms that women can experience. We recently completed a meta-analysis of antenatal and postnatal anxiety, because when you initially looked at the literature, you saw really huge varying rates of antenatal depression and postnatal depression. So with this meta-analysis that we completed, we incorporated over 102 studies from over 30 different countries. 70 studies contributed to the antenatal anxiety data, and 57 contributed to the postnatal anxiety data. And what we found for antenatal anxiety, and if we talk about self-reported symptoms, this is not clinical diagnosis, but self-reported symptoms is what we tend to use in clinical practice, especially in public health or primary care or in the obstetric clinics and midwifery and such. You'll see that in the first trimester, about 18% of mothers had high levels of anxiety. This increased slightly in the second trimester, but then you saw a huge increase in the third trimester. And if we pulled all of this together with 52 studies and over 142,000 women, we see approximately 23% will have a major anxiety episode in their pregnancy. If we move to the postnatal period, we did it by weeks, and we saw that in the first 4 weeks, that approximately 17.8%, or basically 1 in 5 women, had high rates of anxiety. This is from 14 studies, including over 10,000, almost 11,000 women. But after that, if you look at weeks 5 to greater than 24, so across that first year postpartum, you'll see that prevalence rates remain stable at approximately 15%. So in the first 4 weeks, we see some transitional anxiety, but then we see the stability of anxiety symptomatology across that whole first year. And this included over 39 different studies in over 150,000 women. I also did some work on postpartum anxiety risk factors, because we actually have not done a lot of research in that area. So if we're trying to prevent postpartum anxiety, what are some factors that we may want to target? So the risk factors for postpartum anxiety included perceived stress, if they had a couple children, had a history of mental health problems, but interesting enough, multiparous parity and perceived stress were a greater likelihood of mothers experiencing anxiety. than a history of mental health problems. And also if they had childcare stress, that increased the risk of postpartum anxiety. But what we found was two protective factors, which are modifiable and therefore targetable through preventative interventions. The first one is partner support. That cut the risk almost by half, and breastfeeding self-efficacy. So the more confident a mother was in her ability to breastfeed her baby, the less likely she was to be anxious. Epidemiological data suggests that 1 in 4 individuals in the general population will have at least one episode of anxiety or depression. And if you think about that, there's going to be a lot of comorbidity out there. So comorbidity is when you have both anxiety and depression. And to take this into a perinatal field, we did another meta-analysis, and this included 66 studies. 24 of these studies were published, but we contacted researchers from other studies and had them reanalyze their data for us. So we were able to include 42 unpublished results for over 162 people in this meta-analysis from over 20 different countries. And what we found is that antenatally, almost 10% of mothers had very high levels of anxiety and depression during their pregnancy. That included 17 studies and over almost 25,000 or almost 26,000 women. If we move this into the postpartum period, the rate drops slightly, but not significantly, where we see about 8% of women having high levels of anxiety and depression. Why should we care about comorbidity? How does it impact women in a clinical sense? Well, there isn't a lot of work regarding perinatal comorbidity, but if you look at the non-perinatal literature, you'll see that individuals who have comorbidity, so high rates of depression and anxiety, they have more severe and persistent symptomatology, they have increased disability and impaired functioning, they have a poor response to treatment, so they're more treatment resistant, and they have an increased likelihood of committing suicide. And so if we were to think about this in a perinatal context, these are the women that we would really want to target and give them priority treatment in terms of perinatal mental health treatment resources. And so comorbidity, I think, is something that's very important that we should be considering when we talk about perinatal mental health. So I encourage you, as you think about perinatal mental health, to not only include depression, but to also incorporate anxiety, which many of us are now talking about, but not a lot of us are talking about comorbidity. And I think that's a particularly vulnerable perinatal population that should be incorporated in some of the work that we do in the clinical practice as well. Now, I've talked about women thus far in this presentation, and I do know that this is a women's mental health series, but I think it's very important to highlight that perinatal mental health is a family affair. Women do not live in isolation. If we look at a recent meta-analysis of 74 studies, we see that rates of paternal depression, so this is fathers experiencing a major depressive episode in that first year postpartum, it's sitting at around 8.4%. And this is 74 studies, so this is a pretty good prevalence rate that we can reliably use clinically as we think about the programs that we're developing. That's almost double what we see in community-based samples. And it really does suggest that family level interventions are warranted. Although we right now really focus on the maternal child aspect in the provision of perinatal services, we also need to think about the whole family. We do talk about family-centered care, but really we don't deliver interventions at a family level in terms of perinatal mental health thus far. To really look at what type of interventions we should be delivering to these families, I've recently completed a CHR-funded study called the IMPACT study. And in this study, one of the main goals was to look at maternal and paternal postpartum depression and looking at concurrent depression in the family. So that's where both parents are depressed. This is a longitudinal study where I recruited over 6,400 mothers and fathers across Canada. This is 3,200 families are included in this study. And they completed online questionnaires for me at 3, 6, 9, 12, 18, and 24 months postpartum. Just to tell you a little bit about the sample, 35% were immigrant couples, so they were not born here in Canada, and 30% were classified as low income, so they had an annual household income less than 60,000. We also had them complete a wide array of measures, including the Adverse Childhood Experiences International Questionnaire, so the ACEs data we have with this study, which is very popular at this point in time. And we had diverse child development measures included in the study. So not only did we have data regarding the mothers and the fathers in their own particular health, but how they perceive their child growing and developing. The prevalence of paternal depression and anxiety in the first year postpartum, we saw that 27.5% of fathers experienced a major depressive episode. And if we look at anxiety, about half of the fathers in our sample experienced a high level of anxiety at some point in the postpartum period. If we move on to the second year postpartum, about 17% of fathers experienced a major depressive episode. And if we bring that down to anxiety, 1/3 of fathers experienced major anxiety in the second year postpartum. And if we look at the continuation of symptoms of the 735 fathers who experienced depression in that first year postpartum, almost greater than 1/3 of them continue to experience symptoms into the second year. And of the 1,200 fathers who experienced high anxiety in that first year postpartum, half of them continue to experience high anxiety in the second year postpartum. So what we're seeing here is high rates of depression and anxiety among fathers in that first year that often continue into the second year. And one of the reasons why we may see this is that we actually haven't been screening fathers for mental health issues and offering treatment options. So those who do develop this condition, there aren't treatment options, and therefore we often see the continuation of symptomatology. So that could be one hypothesis as to why we're seeing this. So when we plotted out rates of paternal postpartum depression, and if you see the bottom line, which is the black line, that's the overall prevalence rate we found for the whole sample in this study. And what we found is that fathers who indicated that they were very dissatisfied with their partner relationship, they had the highest rates of postpartum depression among all fathers in our study. In fact, at 3 months postpartum, almost 1/3 of them who had indicated that they had marital or partner dissatisfaction, almost 1/3, more than 1/3 of them had reported postpartum depression. Then the next variable or next subgroup of fathers that had high rates of postpartum depression were those who screened positive for ADHD. So that was just part of our measures, but that was actually very telling for us because it was very easy to screen for ADHD, and we found that they also had high symptomatology for not only depression but also anxiety. Then the next cluster of variables are around financial strain. So whether they were unemployed, difficulty in managing under their present family income, or they had a family income less than 80,000 Canadian, those families, those fathers were clustered together of having high rates of depression. And interesting in our study, we had a significant amount of fathers report emotional abuse by their partner. So in the impact study, not only did we look at intimate partner violence reported by the mother, but we also had fathers reported as well. And those fathers who reported emotional abuse by their partner had high rates of postpartum depression. And lastly, I'd just like to highlight that fathers who had a BMI greater or equal to 30 had an elevated risk for postpartum depression in our study. So this just gives you clues as to which are our vulnerable paternal subgroups if we're thinking about perinatal mental health services for them. If we move on to postpartum anxiety among fathers, clearly we see maternal marital dissatisfaction as being a very strong risk factor for having high rates of postpartum anxiety. Again, we see ADHD coming up, so fathers who screened positive for ADHD had higher prevalence rates. And then the cluster of financial strain, we also see the emotional abuse coming out again. In fact, emotional abuse was more important than overall family income. In terms of postpartum comorbidity, so these are fathers that had both high rates of depression and anxiety. Again, marital dissatisfaction came out to be the subgroup of fathers with the highest rates of postpartum comorbidity. Again, paternal ADHD. Then we have the financial issues, the emotional abuse, and obesity. So we're seeing consistency in the subgroup of fathers that were vulnerable to developing depression, anxiety, and comorbidity in the postpartum period. Now I'd like to take a few minutes to talk about dual parental depression. It's been hypothesized that dual parental depression, so this is where both mothers and fathers have high rates of depression, and that we think that it may have additive negative effects on infants and placing them at higher risk for adverse outcomes than those infants who are exposed to only one depressed parent. So I don't have that data analyzed at this particular point in time, but I do want to talk to you about dual postpartum depression, dual parental postpartum depression in this study. And all this data related to impact thus far has not been published. So this is just new data that I'm pointing out to you. We're analyzing the data right now. But with our impact study, what we did is we classified families into one of 4 groups. So the first group is no parent had, so this says anxiety here, it should be saying depression. So again, this is a brand new presentation of this data. So there we go, there's our first error. But just to say for dual postpartum depression, we classified families into 4 groups. So the first group is that neither family had high anxiety or had high depression. The second group is mothers only had high depression, not fathers. In the third group, fathers had high depression, but not mothers. And in the fourth group, both mothers and fathers had high depression. And if you plot this out, you'll see that the families where only the father had high depression, they were the highest group here. So about 10% of families had only fathers with high rates of depression, and that remained constant across time. The second group was families where only the mother had high rates of postpartum depression, and you'll see that this rates of depression, postpartum depression, was lower with mothers than with fathers, and that by the time we reach 24 months, you'll see a significant difference in rates of postpartum depression in the families. So there were significantly more families where only the father was depressed in comparison to families where only the mother was depressed at 24 months. You'll see with the fathers only, there's a significant, as we reported earlier, consistency in depressive symptomatology across time. And when we look at dual parental depression, we'll see that rates are sitting at around 3%, and that remains constant across time, decreasing slightly at 24 months, which is probably representative of decreased mothers with depression at that point in time. If we move on to postpartum anxiety, and again, classifying families into those 4 groups, with this slide, we see that there's more families where only the mother has high anxiety, not the fathers. And then we have fathers with high anxiety, and these prevalence rates are sitting at between 12 to 14%, and mothers with high rates of anxiety, so the families with only mothers with high rates of anxiety are sitting at around 16%. And if you look at dual parental anxiety, so families where both mothers and fathers have high rates of anxiety, you see that it's sitting at around 8%, and that remains constant across time. But the families with most anxiety are those with the mothers only, so mothers and the fathers not being anxious. At 3 months postpartum, 36% of families had at least one highly anxious parent, and that remained constant at 24 months, where 36% of families had at least one highly anxious parent. So we see a consistency in anxiety across the first 2 years postpartum. We also see consistency where only the mother has high anxiety, versus only the father having high anxiety. So we see a consistency across time, which is really nice as we think about treatment options and interventions for these families. So again, to reiterate, although I do understand that this is a women's mental health series, perinatal mental health, if we really want to target this and really improve clinical outcomes for children who are exposed to parents that have depression, anxiety, and comorbidity, we need to think about it in a whole family context. Especially now that we're seeing with the Canadian data that there's more depressed fathers than there are depressed mothers in the postpartum period. Again, if we want to prevent poor child developmental trajectories, I've said that we need to focus on the whole family, but I also think we need to think about the timing of when we offer these interventions to families. I really do think that we need to initiate management before pregnancy. And that can be challenging, but let me just talk about that gap in the continuum of care that we have in terms of mental health services. If we think about when we try to address perinatal mental health for women, or just how they enter the healthcare system, the first contact that women have with antenatal care is really too late for us to provide any advice regarding improving their health behaviors or the social environment that they live in. So the things that we tend to target for preconception care, such as health behaviors and social environment, it's really too late to target these risk factors with our first contact because we've missed that whole first trimester. And if you think about this in terms of mental health care, I really think we're missing the ball in terms of treatment of antenatal anxiety and depression. The first trimester is completely missed. The second trimester, we may or may not identify. We don't have universal screening programs across this country. It's right now at a provincial level, and it's basically at a regional level, though you've been doing a fabulous job in British Columbia, trailblazers in Canada. But identification is definitely not universal. If they are identified, then there's a referral pattern that is often made to external services outside of the obstetrics care, and then treatment is initiated. And that all sort of happens in the second trimester. And the third trimester is when the mother's receiving treatment, and that obviously depends on her levels of symptomatology. But something like cognitive behavioral therapy or interpersonal psychotherapy for mothers who have moderate to severe symptoms, that's often a course of anything between 10 to 12 weeks of weekly sessions, or it could be group sessions. But you'll see that the treatment will go on into the third trimester, and hopefully by the end of that trimester, they'll have remission. But if you look at this, that fetus has been exposed to a mentally unwell mother, throughout the whole pregnancy and while they're in utero. So even though we are initiating treatment and trying to address antenatal mental health issues, we often don't initiate that care early enough to prevent the negative effects for the children. So that's why we need to really be thinking about preconception care. What is this? The World Health Organization defines it as the provision of preventative, promotive, or curative interventions intended to identify and modify biomedical, behavioral, and social risks in women of reproductive age. And when we think about preconception care, again, we often think about the mother-to-be, but I think it's really important to also say that fathers have poor health behaviors, have mental health issues preconceptually, and that they should be considered in preconception care as well. Again, taking that whole family level approach. If we were able to incorporate the management of mental health services preconceptually, or the management of mental health issues preconceptually, then I really think that we have a great opportunity to prevent antenatal depression and anxiety. Right now, I do a lot of the Cochrane systematic reviews around prevention and treatment of anxiety and depression, either antenatally or postnatally, and I can tell you there's not a single trial out there that has been completed related to the prevention of antenatal depression and anxiety. Preconception care provides us with that opportunity. This is where I'd like to introduce you to the HeLTI initiative, which is the Healthy Life Trajectories initiative. This is a study that's being conducted. It's an international collaboration with the WHO, and is to develop linked intervention cohorts that will implement and evaluate approaches to prevent overweight and obesity in children and risk factors for non-communicable diseases, and to improve early child development. The goal of this initiative is to decrease the burden of non-communicable diseases, including diabetes, obesity, cardiovascular disease, and poor mental health around the world. So it's a very lofty goal, but you have to start somewhere. And this study is being conducted in 4 different settings, one here in Canada. Another one is being conducted in Soweto, South Africa. Another one is in Mysore, India. And the last one is in Shanghai, China. And what we plan to do with this initiative is to recruit over almost 23,000 women with about 11,000 pregnancies. And what's really important about these studies is that they're preconception trials. So they all start preconceptually, and we try to improve parental health behaviors and preconception risk factors for poor pregnancy outcomes. And one of the goals of these 4 trials is to treat mental health issues or deliver preventative interventions preconceptually, so that we'll see decreased rates of antenatal anxiety and depression. There is a Canadian component to this, as I've indicated, that's led by myself and my colleague Catherine Birkin at Sick Kids Hospital. And what we're doing is conducting a randomized controlled trial. We're going to be randomly
Cindy Lee,
Yep.
I think you're
my last slide.
okay.
So
I know you're busy. Go ahead.
Yeah. So we've got 2 groups here. One's a preconception group that the intervention starts, and then we follow them to the child's age 5. This is the child conceived in the pregnancy. And then we have a control group. We're going to recruit over 5,200 families. The majority of them are primiparous women that have just had a baby. And then we're going to provide preconception care to these women as they plan to have their second baby. And that's based on Canadian fertility rates and child spacing data. And so we hope to have 3,600 children in this study. So that's my last slide. Sounds like I've gone over, so sorry about that, Lisa. But I wanted to introduce that study. We're launching it on January 4th, and it's going to be the first preconception trial conducted here in Canada, where we're taking a family-based approach and recruiting over 5,200 families. So thank you. Just want to say that it's been a pleasure to present to you today. I've talked to you about postpartum depression, anxiety, comorbidity. I've talked about fathers and how they need to be incorporated in perinatal mental health services. I've also talked about dual parental mental illnesses and how that's a particularly vulnerable family that we need to target. And the only way that we can target these vulnerable families is that we incorporate fathers into identification programs that we already have set up for mothers. And lastly, I've talked about preconception and how that's a wonderful opportunity to try to prevent antenatal mental illnesses such as depression and anxiety. So thank you.
Thank you, Cindy Lee. So again, right, you can hear my audible clap, but if people want to send their little emoji claps, that would be great. Thank you so much. Cindy Lee, I know that you are busy and have another appointment to go to. So very quickly, there's a couple of questions. So that's the other reason why I interjected for you.
Yeah, that's no problem.
But it was really fascinating, and I have a million questions actually, but I will ask the one, I'll be the good host and ask the ones that are on Slido. So first, Carolyn Wallace asked, what are some theories on why anxiety is increased by trimester? Is it just temporal proximity to the birth, motherhood, or do you think there are other factors as well?
Well, I think that there's other factors as well. I mean, obviously, childbirth is impending and a lot of people feel anxious about that. But also it impacts their sleep. So women are sleeping less. They're, not able to move around as much. And so I think that there's it's a very complex issue as to why we see an increased rate of anxiety across the perinatal period. But I think that also, depending on how well that couple is getting along, just thinking about what's going to happen after the birth of the baby as well. So there's probably a multitude of reasons why we see an increased rates of anxiety across the antenatal period. Right. I think sleep's a big one, though, quite honestly.
I'm certain. And then another question on Slido is, of perinatal women who experience anxiety, have any links been made to post-traumatic stress disorder? And is it related to traumatic birth-related experiences?
Yeah, so I can't say that I'm an expert in post-traumatic birth experiences or post-traumatic stress disorders, but absolutely, I'm 100% confident that there is a link. In fact, you know, post-traumatic stress disorders are a significant stressor that individuals experience, and we know that that is a real strong risk factor for depression and anxiety. So I think that people that have a history of having a traumatic birth or having some traumatic experience in their life where they've been diagnosed with post-traumatic stress disorder, 100% these women are vulnerable in the perinatal period.
Okay, thank you so much, Cindy Lee. I'm going to ask you to stop sharing your screen. And I just, so that we don't ignore DAGs, I know it's a women's health conference. I really wanted it to be centered on women because women are often ignored, but DAGs obviously are very important. Men's health is very important as well.
And I just
So
want to say thank you for also being patient with my new slides and trying to present this new impact data. It's not totally glued together, but it's very interesting, and it gives us an idea here in Canada what we need to do as we move forward in the development of these perinatal mental health services.
Absolutely. No, it was really, and like I said, I have more questions, but I will be quiet for now.
Great, thank you.
Thanks so much. Now it's my distinct pleasure to introduce Dr. Benicio Frey. I hopefully pronounced that properly. Dr. Frey is an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University, which is in Hamilton, Ontario in Canada. He's also the medical director of the Women's Health Concerns Clinic at St. Joseph's Healthcare Hamilton and the academic head of Mood Disorders Program. His research is primarily focused on understanding the neurobiology of mood disorders with an emphasis on women's mental health. And he has more than 190 publications in peer-reviewed journals. You guys are making me feel like it doesn't matter how I feel. I'm very happy to introduce you. And he's presented his work at numerous national and international conferences. Dr. Benicio Frey is an MD and a PhD. What's hilarious is that in his fun fact, he said as a child, he always said he would not want to be a doctor. And then be careful what you say you're never going to do. I said I was never going to marry an engineer, and I did. So just be careful about saying that is the advice I'd say. Thank you. Take it away, Dr. Frey.
Thanks, Lisa. And it's a distinct pleasure for me to be here, you know, be part of your tremendous initiative. And, you know, congratulations on being one of the most cited researchers, and that's a big accomplishment. It's not just about number, but it's about impact, and the impact of your work is very well received worldwide for sure. And it's also a distinct pleasure to share the panel today with Dr. Dennis and Dr. Wei, that you know, are tremendous researchers that I read so much about and push the women's mental health or women's health agenda forward. So as a clinician scientist, you know, I see patients twice a week regularly. So my talk today, I'll give a little bit of a clinical perspective to what we spoke about today. These are very quick in my disclosure. I had a neuroimaging study that I published 2 years ago, you know, sponsored by Pfizer, and that's about it. So I'll start off with my conclusions. So I hope I will convince some of you that there is a high comorbidity rate between mood disorders, and when I say mood disorder, I say major depression and bipolar disorder, and women's reproductive life events like premenstrual, postpartum, perinatal disorders, or worsening of their disorders in those periods. I also hope to convince some of you that this comorbidity between mood and premenstrual disorders, which I will focus on, is associated with worse clinical outcomes, so we need to pay attention to that. And I also want to say that at the end that hormonal treatments, for instance, transdermal estradiol, combined oral contraceptives, and maybe in the near future brexanolone, which is an analog of allopregnanolone, are useful tools, clinical tools for our patients in many cases. So let's talk about mood disorders and reproductive life events first. So we know that the majority of women will report at least one premenstrual symptom, but the majority of them, these symptoms will not affect their lives whatsoever. About 20 to 30% of women will say that they have regularly a constellation of emotional and physical symptoms that occur in almost all premenstrual periods. But again, for the majority of those individuals, these symptoms are not severe enough to cause major distress or interfere with their lives. But there is an important percentage, about 1.5 to 6.5% of cases that the symptoms of premenstrual dysfunction are severe enough to impair their ability to function, or even if they function, it causes major emotional distress. And this study was the one that really, sparkled my interest in this relationship, because what they did, it's over 1,000 women in the community. It's a German study. They went to their homes. They did a formal psychiatric assessment using, formal psychiatric questionnaire. And they saw that, and then they went back to their homes 4 years later, and they redid the diagnosis to see the stability of the diagnosis. And what they found is that women with premenstrual dysphoric disorder were way more likely to also have a comorbid affective disorder. And most of the signals you can see here is related to bipolar 1 and bipolar 2 disorder. So 8 times the rates of bipolar disorder in women that also qualify for premenstrual dysphoric disorder. So that's speaks volumes in terms of, being a comorbid condition. And then more recently, this is a Brazilian study done in the southern Brazil that actually pretty much replicates what they found in Germany. High rates of MDD and bipolar disorder this is again a community-based sample, large sample, 700 women. Those with PMDD had higher rates of affective disorders compared to those with no PMDD. In terms of the perinatal mental health, Dr. Dennis already alluded to that very well, that the highest, the most important risk factor of postpartum depression is having had previous depression. And this is very clear in this very large Swedish medical birth register study, where they looked at, the rates of postpartum depression across the postpartum period. And you can see here you have women with previous history of depression versus non-previous history of depression. And you can see that, the rates are very clearly different with a risk ratio of 21, so which is very, very significant. And then if we ask about bipolar disorder specifically, this is Vera Berging's group from Rotterdam. They published this major meta-analysis looking at the overall postpartum episodes in women with bipolar disorder, and they found that the rates were 37%, which is the highest rate that you will find in the literature in terms of risk for mood episodes in the postpartum period. And there's a treatment, changes that relapse risk. So they found that in those who were treated, the rate was about 23%, whereas in non-treated women with bipolar disorder, 2 out of 3 had a relapse into a mood episode in the postpartum period, which is very, very, very high. What about the menopause transition? So this is Joyce Bromberger's and group, their work in the SWAN study, the studies of women's health across the nation in the US, where they also did the gold standard psychiatric assessments in premenopausal, perimenopausal, and postmenopausal women, particularly in the early postmenopausal women. They found higher rates of depression compared to premenopausal women, again linking menopause transition with the risk for depression. So what about illness burden and comorbid PMDD? So we conducted a neuroimaging study where we recruited healthy controls, women with PMDD, prospective assessed, women with bipolar disorder, no PMDD, and women with a comorbid bipolar disorder and PMDD. And we did neuroimaging, clinical questionnaires, blood work, in the mid-follicular, and then again prospective in the late luteal phase of the menstrual cycle. And what we found is that clinically, women with the comorbid bipolar and PMDD, they have more subjective biological rhythms change, of course, more subjective depression and manic symptoms as well, and more state anxiety. And what is important here to say is that all of these women were clinically euthymic to be eligible for the study. So even during periods of clinical stability, there is higher subthreshold symptoms of depression, anxiety, and abnormal biological rhythms in women with a comorbid condition. From the neurobiological standpoint, we found that there was a number of brain regions when there was a cortical continuum when we compare women with bipolar PMDD versus women with bipolar no PMDD, cortical thinning in various areas of the frontal, temporal, and parietal cortices. And in one area, we actually saw cortical thickening, particularly in the left superior temporal gyres. The changes are not very big, as you would think, in major mental illnesses, but enough to say that from the neurobiological standpoint, from the cortical structure standpoint, these women appear to have a different phenotype, neurobiological phenotype. And from a brain functional aspect, when we did resting state fMRI, we saw that the seed, when we put the seed in the hippocampus, we found that in women, a number of areas of brain connectivity dysfunction between the hippocampus and various areas of the prefrontal cortex in women with bipolar disorder and PMDD compared to the other groups. We partner with the STEP PD research group to examine the burden of illness of women with PMDD in a very large longitudinal naturalistic study of women with bipolar disorder, so over 1,000 women. And we found that those with PMDD had higher rates of other comorbid conditions, such as anxiety disorders, alcohol dependence, and so on, PTSD, and so on. But to me, what was very intriguing to find was that the onset of bipolar disorder was shorter, about 1.5 years shorter, and closer to menarche than in women with no history of PMDD, which suggests the menarche as a potential trigger for bipolar disorder in those women who have the diathesis of being sensitive to the premenstrual hormonal changes. So I found that very, very interesting. And then the other aspect of increased illness burden is suicide. So this is a recent meta-analytical study, over 3,000 individuals, where they looked at, you can see here, rates of suicide attempt and suicide death, so completion of suicide across the menstrual cycle. And they found consistently more attempts and more psychiatric admissions at the premenstrual and menstrual phases compared to the other phases of the menstrual cycle. So linking suicide risk with the premenstrual period. And interesting in this study, these risks were not elevated in just perhaps a protective effect of oral contraceptives in this suicide risk. So now moving on to our to the third part of the talk, the hormonal treatments. So if we look at the approaches, these are, randomized control. If we look at randomized control trials that attempted, pharmacological and non-pharmacological approaches for alleviation of PMDD symptoms, we see that down here at the hormonal treatments have been found to be effective for some individuals. And where is the evidence? So the evidence is here. So the hormonal treatments are considered by some clinical guidelines as the second-line treatment for PMDD after antidepressants, which are considered the first line. So this is what you're seeing here is a Cochrane database review. And there are at least 5 randomized controlled trials that use oral contraceptives against placebo for women with PMDD, and with 4 different compounds. Only one compound was done in 2 different trials, which is what you can see here, drospirenone with 20 micrograms of ethinyl estradiol, and they were both positive. So there is some evidence of that oral contraceptives are indeed effective for alleviation of PMDD. And then with our work in bipolar disorder, when I did a review with my colleague Luciano Minuzzi in 2013, we published that there were nothing to guide us clinicians how to best treat those women with comorbid bipolar disorder and PMDD, because we are concerned about overuse of antidepressants in women with bipolar disorder. So think about, you finally stabilize someone from a bipolar disorder standpoint, and that person is suffering from PMDD. Do you want to really add an antidepressant to someone who is really finally stable from the bipolar disorder perspective? So what we are pitching in this article here in the Journal of Psychiatry and Neuroscience is that if medication is required, consider a hormonal agent first instead of adjunct antidepressants for women with bipolar disorder. Of course, risks and benefits should be carefully considered. Given the time constraints of this talk, I don't have enough time to talk about the risks and benefits, but I'll be happy to talk about this in the question and answer period or later by email. The use of hormones have also been now a big, in the news for postpartum depression. So this is a big study published by Samantha Meltzer-Brody's team in the US, where they use brexanolone, which is an intravenous formulation of the neurosteroid, GABAergic neurosteroid allopregnanolone, and they randomize women with postpartum depression to various dosages of brexanolone or placebo. And what is interesting to find in these studies that not only the effectiveness of brexanolone was replicated in 2 separate studies, the improvement in postpartum depression was found within 3 days of intravenous brexanolone, which is much, much quicker than what we understand antidepressants in general work, which we need to wait at least 2 to 4 weeks to see the effects of a medication. And sometimes we need to wait until 6 to 8 weeks to see the full effects of that treatment. So here you're seeing that, by modulating the GABAergic neurosteroid, one can improve dramatically the postpartum depression symptoms within a few days, which is remarkable. Now moving on to perimenopausal depression or menopause transition depression. Here in yellow, there are 3 randomized double-blind controlled trials that use estrogen, transdermal estrogen to treat depression in the menopause transition. This first one here was done by Dr. Peter Schmidt and colleagues from NIMH, and they found a partial or full response in 80% of those on transdermal estradiol compared to 22% with placebo. This was his PhD study in Brazil, so a completely separate independent study where they randomized women to 100 micrograms of transdermal estradiol versus placebo patch in perimenopausal depression, and they essentially replicated those results, finding 68% of remission with estrogen versus 20% with placebo. And then yet another independent study from the US that looked at the same design, but in post, not post-menopausal women, then the result was negative. So we are finding here the area of depression is similar to what other areas of medicine are finding, that the early use of estrogen therapy might be beneficial from the mood perspective, but the use of the same treatment later in the menopause transition is probably too late and perhaps even harmful. It's in women above 65 years of age or 10 years over menopause. So these studies actually led to our Canadian guidelines for treatment of depression to acknowledge the use of transdermal estradiol as a potential second-line treatment for women with perimenopausal depression. Of course, the first-line agents for depression are antidepressants and cognitive behavioral therapies, interpersonal therapies, and other forms of therapies that are effective for depression. But at least transdermal estradiol is an option for a specific population. And 2 years later, the North American Menopause Society also acknowledge the use of estrogen therapy as effective for peri, but not the post-menopause women. So now that both Canadian and the North American guidelines have endorsed that. So to conclude, I hope I was able to convince some of you that there's a high comorbidity rate between mood disorders, depression, bipolar disorder, and both premenstrual, postpartum, and perimenopausal disorders, or worsening of those disorders within those periods. The comorbidity between mood and premenstrual disorders, which is an area that trust me, there's not a lot of people paying attention to it in the clinical world. But yet those individuals have a worse clinical outcomes. And so we need to pay attention to the comorbid premenstrual disorders in individuals with primary mood disorders. So that's my clinical pitch here. And then also, it's still an early area, but there's some evidence that transdermal estradiol for perimenopausal depression and combined oral contraceptives for PMDD are effective for some cases, and maybe in the near future, we'll have here in Canada brexanolone available for us to help women with severe postpartum depression. So with that, I would like to thank you all for your attention. This is my email if you want to follow up with me later on, or if you want any of those PDF papers. And it was a pleasure being here today. Thank you.
Wow, Dr. Frey, or Benicio, let me try and say it again. That's very brave of you to put up your email address. So thank you so much. You can hear my clapping. Fantastic talk. I really enjoyed it. And so important, I think, for a lot of people to hear about the comorbidities, because we don't really talk, first of all, we don't really talk enough about PMDD, let alone comorbidities between PMDD and, any other psychiatric disorder. So that was really informative. And I'm wondering what advice do you have for, a lot of women will go to their primary care physician and talk about like, oh, I don't feel well. You feel like irritable. You feel, you might not have a clinical depression, but you might be feeling some of those symptoms, like low level stuff, and talk to your primary care physician, but it's often poo-pooed. Like it's often, that's not a very scientific term to say poo-pooed, but you're often dismissed. And so what advice would you have for women that are seeking something more and seeking some kind of form of treatment and alleviation?
Yeah. So I think a part of it is the lack of education in physicians in general about the women's mental health. It's unfortunate that unless residents are lucky to have, be part of a program that have a strong women's mental health to that, and they can learn that in residency. But we know that it's, women's mental health is not part of a core rotations, or even Royal College, is not pushing that agenda for clinicians. So I think, we need to talk about, the need for women's mental health to be, a big part of the training of the next generation. So I think that will be my overall pitch for the future. But for those who are suffering right now, what I can say is that it's very important that the DSM acknowledge that you need to do daily rating of your symptoms for at least 2 menstrual cycles for the diagnosis to be accurate. And once you have that and you bring that to your doctor, I think it's going to be really hard for the doctor to dismiss that objective measure of symptoms. Mm-hmm. So there are various, tools and even apps these days for people to track their symptoms across the menstrual cycle. So we have one in our Women's Health Concerns Clinic website that we use, that we develop actually for the comorbidity. But I think it's very important for those who think they might have this condition to get one of the tools, whether it's paper or whether it's an app, track their symptoms for 2 menstrual cycles, and then bring that to their healthcare providers and say, look, this is it. This is the gold standard way of diagnosis. And, I want to know if I have, the premenstrual component or not. I also must say that for those women who have comorbid conditions, then we need to treat the comorbid conditions first, and then do the 2-month prospective charting, because sometimes they know they have the premenstrual dysphoria. Their partners know, their families know, their children know, everybody around them know they have, but sometimes it doesn't show up in the prospective tracking, because they also have other either anxiety condition or PTSD or bipolar disorder that also has symptoms, so you can't see the hormonal pattern. So that's why we suggest that the comorbid condition is treated, and then they do the prospective charting, and then you can see the hormonal influence there very clearly.
Yes, so interesting. And I have a lot of anecdotal stories that I will spare the audience from listening to, but there's a question again from Carolyn Wallace. In interventional clinical trials for mood disorders in general, that's a very good question. What menstrual menopausal data do you recommend collecting? Because probably most trials out there aren't even paying attention to this, right?
Yeah, absolutely. So even the diagnosing someone with, what stage of the menopause transition they are. If they're not the gynecologists, psychiatrists have a very little understanding of that, or mental health providers in general. So we need to educate, healthcare providers about, the clinical characterization of menopause transition. So from regular to irregular menstrual cycles, 7 days or more of irregularity, that's the early perimenopause. Missing 2 menstrual cycles, so 2 months of amenorrhea, that's the late perimenopause. Then 12 months with amenorrhea, that's the classic post. First 3 to 5 years is early post, and then after that is late post. So it is in the perimenopause and the early postmenopause transitional periods that the risk for depression is higher. There's a peak, like there are many outstanding longitudinal studies that already show that and replicated that independently. And then, so if you want to have a questionnaire to be able to capture some of the physical, emotional, sexual, and vasomotor symptoms of menopause, I would suggest the green climacteric scale. Green climacteric scale, GCS. This is the one that not only has been used, in some clinical trials, including some that we've done, but we also use clinically. So at the Women's Health Concerns Clinic, we use that questionnaire clinically, and it's clinically very helpful because there are 4 domains. There's the emotional domain or psychological domain, there's the physical domain, vasomotor, and sexual. So when you treat someone, you can repeat that questionnaire, and then you see which domains the treatment is helping and which and then you can adjust the treatment accordingly. So that would be the questionnaire that I would recommend. Green climacteric scale, with E at the end, green, any.
Okay. It's really, one wonders how much, I understand the need for randomized controlled trials and that primary question, but one wonders how much is missed when we don't take into consideration the reproductive cycles of women. It's very possible, right, that we could, first of all, sex differences, but then also reproductive cycles as women, which is part of the reason why I wanted to have this conference and to create this cluster, is to spotlight the need for not just sex gender-based analysis, but also the need for understanding the complexity around women's mental health. I mean, there's complexity around men's health too. So we're actually 2 minutes over. So, but I really want to thank the speakers again for their time. Oh, one more question, and then I'll thank the speakers for the time. Are many of these studies taking into account or differentiating between women who have had a hysterectomy, another issue, or oophorectomy in terms of outcomes? I already know the answer to this. So the question is, are many of the studies even differentiating between women that have had oophorectomies or hysterectomies?
Yeah, so there is actually, so we know that oophorectomy further increase the risk for, negative outcomes, especially in those individuals that don't receive hormonal replacement therapy shortly after the oophorectomy. There is some suggest like the issue of hysterectomy is a bit still up in the air. Like it's less understood because some studies find it positive, some studies don't find. But oophorectomy for sure, because even if you have hysterectomy, you keep your ovaries intact, you still have estrogen and progesterone being produced. But if you lose that, the estrogen being so protective for women's brain, as we know, that would increase risk for mental health problems down the road, including anxiety, including depression, mild cognitive impairment. There is even links with dementia and things like that. So definitely there is a link in terms of surgery and mental health outcomes down the road.
Well, now I shall say thank you to our speakers. We already lost Dr. Cindy Lee Dennis, but she had another important meeting to go to. But I will send her thanks. And if we can give us our little emojicons. I feel bad that I've silenced all these people, so we'll try and find a way to get rid of the Zoom bombers, but not silence the non-Zoom bombers in the audience. So, and you got a heart too. Thank you very much to everyone, and super thank you to our speakers. And we'll find something special to send you from Vancouver, and hopefully find a good excuse to bring you actually out physically when things settle down. So thank you once again to everyone.
Thanks so much. It was a pleasure being here.
Thank you very much, Lisa.
It was my pleasure. I learned so much, so thank you so much.
Thank you.
Bye.
Bye.